Should I have surgery for a meniscal tear if I have knee pain when I'm running? Well, maybe, maybe not. I would say about 3 or 4 times every week I have a chat with a runner who's having knee pain when they're running and they're considering getting surgery on their meniscus because they've had an MRI, because they had knee pain. So they had an MRI and then that showed that they had a meniscal tear. And then a surgeon has proposed operating on that meniscal tear in order to resolve the knee pain. And I would say just as often I speak with runners who've had that surgery in the past and found that often it didn't improve their knee pain at all, or it made it worse. So 2 or 3 months later, as they get back to running, they find that the knee pain they were having is still there or worse. So today I want to talk a little bit about meniscal tears and what they are and what some of the more recent evidence says about how useful the surgery is and whether you should be considering getting surgery on your meniscus. Now, before we get into it, obviously everything I say in this episode is not medical advice for you specifically. This is general information, so you can chat with your medical team about it. But we are going to be taking a critical look at surgery for meniscal tears. Now, before we get into the research nit and gritty, let's just talk a little bit about what we're talking about here. So the meniscus is a shock absorbing tissue in your knee. So if you think of your knee as the joint between your thigh bone and your shin bone, which is your femur and your tibia, in between the two to put some shock absorbency between those two bones, we have the meniscus. It's essentially a squishy pad in between those two bones to add some shock absorbing capability to the knee to help protect the femur and the tibia and their joint surfaces in the knee. And you can tear these menisci. In fact, it's quite common to tear them because they're made of collagen, and as we're sort of moving around through our daily life, at times they will fray a little or they will full on tear sometimes. And there's lots of different types of tears that you can have, and there's different classifications for them. In my experience, most runners with knee pain who've been told they have a meniscal tear do not know what type of tear they have. So I'm going to try and keep it quite broad today. Generally speaking, you can divide these tears into traumatic, which are like acute and come on suddenly, usually with like twisting sports like soccer and basketball, and degenerative, which are more a process of aging where you see this kind of fraying of the meniscus with age that sometimes gets more pronounced in certain regions. Now, I'm going to just stick to meniscal tears today. Most of the evidence that I'm talking about, though, is referring more to these degenerative type tears. The way we're going to differentiate, although this is not an absolute criteria, but if your knee is locking, meaning it's getting stuck and is not moving, in addition to hurting, it just gets stuck sometimes and it full on won't move. And I don't mean just like gets a little stiff sometimes. I mean, it locks and you can't move it. Pretty much nothing I say today is going to apply to you. But if you have knee pain when you're running and you don't have any locking or giving way or anything like that, then what I'm going to talk about today in terms of meniscal tears may be relevant. Now, a common story that I will hear is a runner will develop knee pain. Okay, so this is a really common story. Running is a sport that predisposes to getting knee pain. I've talked about it loads on this show, and essentially usually in most studies it's the most common running injury is knee pain, and it's often called runner's knee because it's so common in runners. So a runner will develop knee pain and then they'll go to their doctor about it. The doctor will then either themselves order an MRI or they'll refer to like an orthopedic specialist who will order the MRI. The MRI will show a meniscal tear. That's usually as much as the runner knows. Like they don't know what type usually, just because they don't think to ask. But there are different classifications of tears, but usually they just know, okay, I've got a tear in my meniscus and I can see it on the MRI. The next step in this sequence is that tear is causing the pain. Now, we're going to come back to that in a sec, but that's the next step in this logical sequence. And then the next step after that is often we will do surgery to trim the tear to stop the knee from hurting because the tear is causing the pain. If we trim the tear, the pain will go away. That's the logical sequence, and that is a very, very common thing that happens in terms of like a sequence of events. In fact, if you look at some of the stats on doing what's called an arthroscopic partial meniscectomy, which is the operation where they take a scope and they trim the meniscus. That's the most common one. That I think there's about 500,000-ish done in the US every year, right? So 500,000 every year. And each one of them costs about 4K, costs about $4,000 US. So it's quite a big business. And if you haven't had a meniscectomy or haven't been offered a meniscectomy at any point, then there's a good chance you know someone who has, or who's had one, or who's been looking at getting one. It's very, very common. Now, we're going to start to examine some of those logical progressions that we just talked about. So the first part that we need to consider is that if you take the general population and did MRIs of their knee, and specifically looked at people who don't have knee pain, right? So you take 100 people with no knee pain and you take an MRI of their knee and they're over 50, right? So they're a little bit, that's not older. My definition of what is old is steadily creeping up, okay? But let's say middle-aged people, right? So you take 100 middle-aged people and you do an MRI of their knee and none of them have knee pain. 30 of them will have a meniscal tear. So about 30% of the population who don't have knee pain have a meniscal tear, meaning they have an asymptomatic meniscal tear. So it doesn't cause any locking and it doesn't cause any pain. And often they don't even know it's there. So I might have one, right? I'm in that age bracket, not quite up to 50 yet, but I'm getting there. And if you were to do an MRI of my knee, then you may well see a meniscal tear. I don't know. I might be one of those 3 out of 10 people. So if you go to the running club and there's 20 runners there and none of them have knee pain, 6 of them probably have a meniscal tear that they don't know about and will never know about. But if they develop knee pain, because lots of runners develop knee pain and they have an MRI quite early in that process, or because they're not getting anywhere because they had crap physiotherapy or something like that, and they end up getting an MRI and then they see the meniscal tear that's always been there and is not causing any pain and is not causing their current pain, then that logical sequence is complete. I have knee pain, now I have an MRI that shows a meniscal tear. The meniscal tear is causing the knee pain. But we know that lots of other structures in the knee can cause knee pain, especially in runners who get knee pain from other structures in the knee very often. So if we have the patella tendon, the fat pad, the back of the kneecap, right? They call that patellofemoral pain. Osteoarthritis, that's the joint surface and the underlying bone between the femur and the tibia. The bursa that are sort of littered all over the knee, some of the tendons surrounding the knee. There's lots of different structures in the knee that can cause pain. Meniscal tears are one of them. So just because you have a meniscal tear on your MRI and you have knee pain, that doesn't mean it's definitely causing the knee pain. And this explains why sometimes, and I talk to these runners often, people will go for the surgery, the meniscectomy, because they have knee pain when they're running, and after a couple of months later, when they've had the surgery and then the tear is no longer there, they've trimmed it out, they still have knee pain when they run. And it's often worse because now they've had surgery and a couple of months off. And we know that not running is not good for your knees. We've talked about that a lot. So this is where that logical sequence can break down a little bit. So the other thing to consider is that when you look at, so now that we know that, right, 30% of people have these tears in the menisci anyway, and it's not causing any problem. When you look at the people who do have knee pain and then have an MRI and then don't have surgery, so they have a meniscal tear, but they don't have surgery. If you wait about 12 months, a lot of them don't have pain anymore. And this can be a difficult thing for runners to get their head around because they're like, well, I've got knee pain when I run. And I've got a tear in my meniscus. I can see it on the MRI. They showed me it. I can't run without pain until something is done about that tear, right? Either it's trimmed or it's repaired or it heals. But that's not true. The tear can sit there and not cause any pain. In fact, if you wait 6 to 12 months, there's a good chance it won't be hurting anymore, even if you don't do anything about it. So this is important to understand, that a lot of people have meniscal tears that does cause any pain, about 30%. And most people who do get a tear in their meniscus that does cause pain will no longer be having pain about a year later. So observing all of this, right, the medical community started to research it to try and get an understanding of when do we need to operate on these meniscal tears, and what are the good criteria to do an operation on them? And when do we not need to do it? And are there any downsides to doing it? And how do the people compare if they had surgery versus didn't have surgery? So that's when they started doing research about this in the last 10, 15 years. And that's some of the research we're going to talk about now. So in the research, there's a lot of research on this topic, like comparing surgery on menisci versus on meniscal tears versus just leaving them alone or sending them for physiotherapy. But I'm going to review some of the key research that's been done. And if you're watching the video, you'll be able to see it. And if you're just listening, don't worry, I'll explain what we're looking at. So the first was back, well, it's not the first, but one of the more notable ones. Back in 2013, Katz and colleagues looked at 351 patients and they assigned them to either having surgery or just doing physio. And they reviewed them at 6 and 12 months, and found that they were doing equally as well. So in terms of pain and function, they were both doing equally as well, both groups, when they compared them. And there wasn't a significant difference between the groups. So they were all doing better. Or like if you had the surgery, you were doing better at 6, 12 months. You had less pain, you could do more, you could run potentially if you were a runner. And if you didn't have the surgery and just went for physio, you were also doing just as well as the people who did. So this is what turns out to be quite a common finding in these type of trials. So then again, if we look at this study from what year was it? 2018, Van de Graaff. And they looked at 321 patients this time, and again, randomly assigned them to either have the surgery, have the meniscectomy, or just do physical therapy. And then they looked at them 2 years later and compared the groups. And then what they found is a not inferior outcome in the physical therapy group, which is the language they used to say they did about just as well. So whether you had physical therapy or you had surgery on your meniscus, 2 years later, you're both doing good, right? But you're doing equally good. So there was no real benefit to doing the surgery, but there wasn't a real drawback either, right? They were doing equally well. And then in 2020, Sivonen and colleagues followed up 5 years later with some patients they'd done their study on 5 years prior, right? So there was 146 of them, and they had degenerative meniscal tears, and they did a placebo surgery. So they just did the arthroscopy, but they didn't trim the meniscus. Whereas so they didn't know, right? Like these 146 people, they were randomly assigned to have sham surgery or real surgery. Real surgery meant they had an arthroscopy, they put the little camera scope thing in, and then they did a trim on the meniscus. The sham surgery, they put the little scope thing in, but they didn't do anything in the meniscus, they just left the tear there alone. And then this is a nice study because both groups thought they had surgery, or they didn't know it at least. They didn't know whether they had the sham surgery or the real surgery that trimmed the meniscus. And again, they found I'll read it out. At 24 months, there was no relevant between group differences in the reported outcome measures. And their conclusion was quite interesting. Meniscectomy was associated with a slightly increased risk of developing radiographic knee arthritis and no concomitant benefit in patient-relevant outcomes at 5 years after surgery. So to translate that, what that means is radiographic arthritis means they could see in the group where they did the meniscal trim more arthritis 5 years later. But even though they could see more arthritis on their scans, they had no more pain. So that's why they call it radiographic knee arthritis. I mean, you could see it on an X-ray or an MRI, but it didn't manifest as any significant increase in pain or dysfunction yet as of 5 years. So what this tells us, and there's another study that found similar things, right? When you take that little bit of meniscus tissue out, arthritis comes on a little bit quicker. But we don't know how much that really matters at the end of the day. Like the studies that have looked at it that I've read found that they had about the same amount, they had slightly more arthritis on their scans 5 or 6 years later, but they didn't have any more pain. So we don't know, maybe that doesn't matter. But what we can say is, unless the surgery is making a significant improvement, it will be better not to do it because then we wouldn't have that slight increased rate of arthritis. So that's something to consider. And then in 2022, these researchers looked at all of those research studies that I mentioned and a bunch of others. They reviewed all of the research, right? And then they just kind of analyzed it and said, okay, what should we say about doing meniscectomies on degenerative meniscal tears? for knee pain, right? So this is not for locking. This is just for knee pain. This was their conclusion. I'll read it out and then I'll translate it for non-research speakers. Okay, the available literature and professional guidelines surrounding meniscectomy for degenerative meniscal tears overwhelmingly demonstrate that exercise therapy and sham surgery are non-inferior to meniscectomy for the treatment of degenerative meniscal tears and suggest delaying surgery until non-operative modalities have been exhausted. So to translate that, when they've looked at all of the research, if you look at 12 months plus, there doesn't seem to be a significant benefit of doing surgery on these meniscal tears. That's the kind of bottom line with the research as of 2024. And that's worth knowing, because if they're doing 500,000 of these surgeries every year, costing $4,000 per surgery, and they're not having a significant improvement based on doing that surgery, you may be in line for one of those surgeries and it may not be necessary. It may be better to consider pursuing good rehabilitation and delaying 6-12 months to see how you're doing, because you're probably going to be doing just as well as you would have been if you'd had the surgery. Now, obviously, this is not medical advice. This is not specific to you. This is looking at that operation among lots and lots of people. So we're talking about hundreds of people now and what the results show. So you want to consider this if you are looking at having surgery on your meniscus, but this is not to say that you should or shouldn't have it, right? You're going to need to talk to your medical team. But if I were to give some thoughts as to what I would do, right? If I had knee pain and I had an MRI that showed I had a meniscal tear, if my knee was locking, I definitely want to talk to a surgeon. If my knee was not locking, then I would be looking at delaying surgery at least 3 to 6 months and doing good rehabilitation. This is a key point because a lot of people go to physiotherapy, chiropractic, whatever. I've talked about a lot on this show, and they don't really do good rehab. What I would define as good rehab, so building the muscles, strengthen the structures, refine the technique, the 3 critical components that I talk about all the time. If you don't do those things and do them in a very comprehensive way for a good period of time, 3, 4, 5, 6 months of working in close contact with your team of rehab professionals to get you there, to walk you through the steps and get you all the way back to running pain-free, like we do in our recovery program. If you haven't done that, if you've just been for a few physio sessions, they gave you some exercises, stuck you in the corner, maybe stuck some electrodes on you, like that's crap, right? That is not what we're talking about. If you do really good rehab, right, and you're convinced that you've done everything you can over that 3 to 6 months and your knee pain is no better, and you talk to a surgeon and they say there's a meniscal tear in there and you should probably consider having surgery, then it is definitely worth considering. But there doesn't seem to be any downside to delaying. That's the other thing that they concluded from the research, is that if you wait 3-6 months and try good rehabilitation, you can still do the surgery. There's no real downside to delaying and giving rehab a go. You don't have to do it as soon as you get the knee pain or as soon as you have the operation proposed to you as an option, right? That you can delay it and try rehab. So if you are, I mean, obviously this is going to raise questions for you if you're looking at having this surgery or if you've had it, and if you would like some help, right? If you're having, obviously the reason you would have this problem, right, is I've got knee pain when I run, right? Like that's the problem. Like my knee hurts when I run, and meniscectomy might be one option to you. But if you, excuse me, if you would like to look at other options like good recovery in terms of good, build the muscles, strengthen the structures, refine the technique, get rid of the knee pain that way, we'd love to talk to you. Like just click the link in the description as usual, book a call, and we'll have a chat.